My name is Casey Carr, and I am a critical care fellow at the University of Florida. And today I am going to be talking about auto-PEEP in the emergency department. So let's start with a case. We have a 63-year-old female with COPD who presents with worsening dyspnea and intolerably high workup breathing. She's intubated upon arrival to the emergency department and develops increasing airway pressure and hypotension. This patient has auto-PEEP. How should we manage the ventilator? Auto-PEEP is also known as intrinsic PEEP and is defined by an incomplete exhalation prior to an inspiratory breath on the ventilator. Why does it matter? Well, ED crowding is getting worse. ED length of stay is getting worse, especially in patients who are waiting to go to the ICU. We will be troubleshooting ventilators, and this is especially true in the era of COVID. So we discussed how the problem with auto-PEEP centers around exhalation. And there are patients whose pathology prevents them from complete exhalation as well. First, we'll talk about COPD. And their pathophysiology has both airway obstruction as well as alveolar destruction. These patients have both mucus plugging and alveolar destruction called emphysema. Patients with asthma are also especially prone to auto-PEEP, and this is mainly because their primary pathophysiology is airway obstruction, but they do not have emphysema, so these patients will have very, very high airway pressures. And these are the 5 signs of auto-PEEP. Failure to trigger a breath on the ventilator, failure to return to baseline on the flow time curve, elevated end expiratory pressure, elevated plateau pressure, and hypotension. First, failure to trigger breath in the ventilator. Auto-PEEP results in a very high inspiratory threshold. And so the patient will try to breathe and the ventilator will not deliver a breath. And the waveform will look like this. Patients will also have a failure to return to baseline on the flow time curve. You can see between these two breaths, the exhalation curve does not return to 0. And this should clue you in on the presence of auto-PEEP. You can measure auto-PEEP by performing an end expiratory hold maneuver, which will give you the end expiratory pressure. You can see here on the graphic that an expiratory pause results in a higher pressure than the applied PEEP. As end expiratory pressure increases, volume increases, and the patient's compliance decreases. So if the patient has high plateau pressure after intubation, auto-PEEP needs to be on your differential. As intrathoracic pressure increases, preload decreases, which ultimately results in cardiac collapse. Any patient who is mechanically ventilated who develops hypotension, you have to consider auto-PEEP. But what can we do about it? So first, if you think the patient is unstable due to auto-PEEP, you have to disconnect the ventilator and compress the chest to expel or retain lung volumes. But what can we do with the ventilator when we reconnect the patient? The ventilator can only control inspiratory time, but not expiratory time. Since you set the respiratory rate and inspiratory time, you must decrease the inspiratory time or reduce respiratory rate. If you're using volume control breaths, inspiratory time depends on tidal volume and flow rate. If you're using pressure control breaths, you set the inspiratory time. So let's demonstrate the concept. You set a respiratory rate of 10 breaths per minute, a breath every 6 seconds. You also set an inspiratory time of 0.5 seconds. So your total breath time is 6 seconds, and your expiratory time is 5.5 seconds. Now you set a respiratory rate of 12 breaths per minute. So your total breath time decreases to 5 seconds, but your inspiratory time remains the same. That means that your expiratory time has now decreased to 4.5 seconds. Now let's reset to 10 breaths per minute again, a breath every 6 seconds. And we'll set an inspiratory time of 0.5 seconds. And just like last time, that means our expiratory time is 5.5 seconds. Now we'll extend our inspiratory time to 1 second. You'll notice now that even though our total breath time is 6 seconds, our extra time is now decreased to 5.8 seconds. Thank you for your time. I hope that was helpful.
Levine, take 1500. Hi, I'm Dr. Heidi Levine. Welcome to the importance of self-care and why macaroni and cheese is a part of it. Excuse me while I have a little self-care. I just had a bowl of mac and cheese. Better. So today, I'm going to teach you about the importance of self-care, what self-care is, why physicians generally are not good at it, and how mac and cheese plays a role. A simple definition of self-care is having your basic mental and emotional needs met. A roof over your head, healthy diet, water, rest, friends and family that love and support you, and some exercise are the basics. The truth is, doctors are pretty lousy at self-care. Think about it. Before COVID, we had the highest rates of depression, anxiety, burnout, and suicide compared to people in other professions. We talk about well-being, but that's a state of being. We need to talk about resiliency because being resilient allows you to bounce back from stress and adversity and move forward in a positive manner. Physicians, well, we have some fabulous characteristics: selflessness and dedication, stoicism. But those characteristics can also become our own worst enemies. The Medscape physician burnout and suicide report showed that most physicians deal with stress by isolating themselves. And 60% said they wouldn't get professional help for an emotional issue because they don't have the time or it wasn't bad enough. We desperately need to start taking better care of ourselves, or there won't be any physicians to take care of the patients. We must learn about self-care. And that's easier said than done because the list of excuses for self-care is endless. Oh, I can't do it. I don't know, it's a sign of weakness. I feel guilty. I don't have time. Too tired. You're too tired to take care of yourself? We're going to face some rough waters in life, and we have to be prepared. John Kabat-Zinn says, you can't stop the waters, but you can learn how to surf. So, what are some good self-care skills we can learn? Exercise, having positive relationships and socializing with our friends, meditation, a gratitude practice, laughter, and a healthy dose of self-compassion is important. The Thrive study shows us that if we make self-care part of our routine, it will become part of a habit. And it also shows that meditation enhances our well-being, and using problem-solving coping skills is the best way. The 3 Good Things study show if you answer the question, what were 3 good things that happened today and what was your role in it? The common themes are having a good day at work, supportive relationships, and good use of your time. The PERMA study from Marty Seligman showed using positive emotion, engagement, relationships, having meaning in your life, and being proud of your accomplishments actually results in more happiness, better health, and more success. Meditation has been the most studied method of bringing long-term positive results to us. Things like increased life satisfaction, decreased stress, anxiety, and depression. And you can do it anywhere. What about at work? Well, take a break. Doctors that take breaks make less medical errors, have faster door-to-patient times, as well as faster admitting times. And attendings, it's up to you to model this behavior. Another good self-care tip is making sure you protect your time off. You have to get rid of the physical and emotional stress after a shift, and fitness is a great way. Just protect your time, schedule it in. So, socialization remains something that's a key in self-care. Make sure you're sharing with your friends and get some good sleep. It's a cornerstone of actual adequate self-care. And now the mac and cheese, well, we know that stress can cause us to eat, but did you know that certain carbs actually, blunt our stress response? That's where mac and cheese comes in, at least for me. Self-care may be difficult to learn, but it actually leads to resilience, which we all need. So don't forget to breathe, exercise, hang out with your friends, and why don't you try a bowl of mac and cheese? Thank you for your time.
Hello, everyone. My name is Patrick Erling. I'm a PGY2 emergency medicine resident at Eisenhower Medical Center. And
I am Dr. Ibanez, one of the attendings in the emergency department at Eisenhower Medical Center.
we're here to present to you Hablo Español. So a 77-year-old female comes into your emergency department with a chief complaint of right-sided hemiplegia. Your nurses start to assemble and they get IV access, and that not-so-secret TPA clock goes off in your head. And you introduce yourself, and what do you hear?
No hablo inglés.
Wow, I don't speak Spanish. Oh, snap. I'm looking around, I'm looking everywhere. I'm trying to find a HUC or a nurse or someone who speaks Spanish. It's 3 a.m. in this rural ER, and unfortunately, my phone is dead, and no one speaks Spanish. So what do you do, Dr. Ibanez?
I don't know. It's up to you. I'm not there with you.
So, yeah, those high school Spanish classes didn't really pay off so well for me. But doing my best, I'm thinking through everything. What resources do I have? And so that leads us into
The NIH score.
So the NIH stroke scale, is there a Spanish version?
Not that I'm aware of. Maybe there is.
Yes, there is. And so unfortunately, not many of you know this. There's a study actually done in 2017 about the NIH stroke scale, and 35 emergency medicine residencies were surveyed, and 75% of the survey respondents, they had no clue about this stroke scale. It was in Spanish. So that's a problem. So in 2006, NIH stroke scale came out with the Spanish version. Now the original NIH stroke scale came out in 1980. And this was an updated version because there's a lot of people that speak Spanish in our country.
Yes, there is. Apparently, it is the second most spoken language in the world ahead of English. And in the United States, the population, 18.5% of the entire population is Hispanic. And not only that, 13.3% speak Spanish at home. So we need to understand and know Spanish, and mostly talk Spanish in the emergency department.
Definitely great. So what happens? You're in that rural ER, and you're like, okay, well, I remember this talk at SAEM on Ignite, and I want to use that NIH stroke scale in Spanish. So you go to the NIH website, and you go to the health professional resources page, and there's no Spanish version.
Apparently there is one, but you have to order it.
You do, yeah. So you can order the toolkit. It'll be here in 2 to 3 days, and you'll have to pay $35. But there's no full online health Spanish professional PDF for your resources. So at Eisenhower Emergency Department, we spent a good portion of elective on our Spanish medical elective focused on this because this is a huge need in our population. And so we created a Spanish supplement, which if you have time and you have your phone nearby, please scan this QR code and kind of work along with us as we go through the Spanish command supplement that we created.
And here we go. ¿Cómo se llama?
What is your name?
¿Dónde estás?
Where are you?
¿Cuántos años tienes?
How old are you?
¿En qué mes estamos?
What month is it?
Abra los ojos.
Open your eyes.
Cierre los ojos.
Close your eyes.
Apriéteme la mano.
Squeeze my hand.
Siga mi dedo sin mover la cabeza.
Follow my finger.
Abra los ojos.
Open your eyes.
¿Ves el dedo?
Do you see my finger?
Cuente los dedos.
Count my fingers.
Sonríe.
Smile.
Levante la pierna, brazo,
Raise your leg or arm.
derecho, izquierdo,
Right or left.
palmas arriba.
Palms up.
Toque su dedo a la nariz y tóqueme el dedo.
Touch your finger to your nose and touch my finger.
Siente igual,
Sensation equal?
derecho, izquierdo.
Right or left?
Cierre los ojos. ¿Siente que lo toco?
Close your eyes. What side do you feel?
¿Qué es esto?
What is this?
Repita. Lana sube, lana baja.
Repeat. Yarn goes up, yarn goes down. So this Spanish command supplement has been used for approximately 3 months in our emergency department. It's posted up. It's right at our stroke command center that every patient comes into that is evaluated. And it's actually received strong support with our non-Spanish speaking faculty.
And they love it very much.
And so the hope is that we can really impact our community, especially in the few seconds that we need to evaluate these patients before they go off to CT imaging.
Yes, we do. And I think this will help you very much. I hope it really does.
Thank you for your time.
Hi, my name is Molly Boyd. I am an emergency physician and medical toxicologist at Albany Medical Center in Albany, New York. Today we're going to be discussing emerging drugs of abuse and new psychoactive substances. I have no disclosures, and let's start with a case. We've all had this patient. They're agitated, combative, and quite frankly dangerous. 6 of your staff members are trying to hold them down and having a difficult time doing so. The only thing you know is that they are on some new drug. With over 800 synthetic drugs identified within the last 10 years, they can be on literally anything. Let's talk illicit chemistry 101. Peaking in 2015, dozens of new psychoactive compounds come on the market every year. Developed in covert labs like this, they can be sold in packaging like this, legally as a research chemical or fish tank cleaner. But how do you know what to make? By looking at the neurotransmitters we already have. The major neurotransmitters share a phenethylamine backbone. Minor changes to this structure change its kinetics, can make it more sympathomimetic, like epinephrine or norepinephrine, or dopaminergic and serotonergic, which can cause hallucinations. The first widely used derivative of the phenethylamine backbone was the alpha-methylated version, amphetamine. It was used in the 40s to keep fighter pilots awake on long missions. The methylated version, methamphetamine, is more lipophilic, longer acting, and much more addictive. Looking for the high of methamphetamine but want to hallucinate too? That's where cathinones come in. Methylcathinone was the first bath salt synthesized in 1928, but was rediscovered in 2003 and has had a notorious reemergence onto the scene that continues to this day. It's hard to get into the mind of somebody who's on substances. Brian Sanders is an artist who takes psychoactive substances and then draws self-portraits while high. This is him on THC, this is him on cocaine, and this is him on bath salts. Mind-altering to the max, cathinones cause a sympathomimetic toxidrome with often persecutory hallucinations and self-harming behaviors. These patients are a danger to themselves and to others. Although the phenethylamine-derived methylone backbone is Schedule 1, hundreds of analogues are still available on the black market and dark web. Minor modifications, a methyl group here or a halogen there, change binding kinetics, blood-brain barrier penetration, and can change symptoms and side effects. Party kids and ravers may think that their Molly or ecstasy is a safe party drug, but in addition to the risks of MDMA, remains a likelihood you're going to get a dangerous substitution, as MDMA is structurally very similar to bath salts. If phenethylamine derivatives aren't your thing, there's always synthetic cannabinoids. These man-made THC analogs are sprayed onto any old dried plant material, can be smoked or made into tea. Sold as legal marijuana, this can't be detected on standard blood or urine tests. Synthetic cannabinoids look to the brain and the body like THC, but bind the CB1 and the CB2 receptors with a much higher affinity. They were initially developed as pharmaceuticals, but had many undesirable side effects, which rendered them unprofitable. Symptoms of K2 are dose dependent. At low doses, they cause relaxation and euphoria, but at higher doses can cause tachycardia, hypertension, and agitation, but decompensation into bradycardia, hypotension, and the triad of seizure, coma, death are possible. Synthetic cannabinoids were first synthesized in 1988 as analgesics. Outbreaks of novel compounds occur yearly. Over 200 compounds are now identified, and production outpaces identification by at least tenfold. K2 was designed to be smoked just like marijuana, but the other designer drugs can be taken intranasally, can be injected intramuscularly or intravenously, but can be taken orally, or can even be taken transrectally if you so desire. We've talked about bath salts and their toxidrome, synthetic cannabinoids and their toxidrome, but truly these substances only make up the tip of the iceberg for novel psychoactive substances that can be purchased to this day online. There are many other designer drugs that we see that have a combination of sympathomimetic toxidrome and psychotic features or hallucinations, such as N-bomb, piperazine derivatives, 2CE, bromo dragonfly, and even ketamine analogs. So how do we know what they took? We don't, and chances are they don't either. Most recreational drugs are adulterated in some way, and you don't always get what you pay for. Drugsdata.org is a database where for $40 you can send in your pills and have the substance analyzed to identify its makeup. So this is what the database looks like. And you can send in your chemicals and find out that your cannabis might actually have synthetic cannabinoids in it. Your cocaine, it might have ketamine. Your Molly might have 2CB. And Flocka, well, that's a bath salt. So we don't know what they took. They don't know what they took. How do we treat them? A toxicologist's best friend. Benzos, 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 benzos. If the question is, should I give this patient more benzos? The answer is generally yes. There's no specific treatment for these patients, aggressive sedation and airway monitoring, watching for seizures and serotonin syndrome, but there's no specific blood or urine tests to identify the toxin in a timely manner. We are left to supportive care, which we are all.
Good morning. My name is Jeffrey Lazar, and in the next 5 minutes, I hope to increase your consciousness and knowledge of patient safety by reviewing some of its history and some of the associated contemporary issues. The concept of first do no harm is often falsely attributed to Hippocrates, but is actually traced back to Dr. Thomas Sydenham, sometimes known as the English Hippocrates, who popularized the phrase. And he's one of my heroes and has some great quotations, including that the arrival of a good clown is better than 20 asses laden with drugs, and that more people have likely died from the treatment of gout than from the disease itself. From a bioethical perspective, what we're talking about is non-maleficence, right? Given an existing problem, it may be better not to do something or even to do nothing than to risk causing more harm than good. Arguably the parent of modern Western medicine patient safety is Dr. Semmelweis, who demonstrated that medical students were killing postpartum patients by not washing their hands after going to cadaver lab, and when their hands were washed, lives were saved. For this, Semmelweis was ridiculed by the medical establishment and ultimately had his career and his life destroyed. More contemporary disasters include lobotomies. That's Dr. Walter Freeman, the father of American lobotomies, graduate of Penn, who destroyed thousands of lives, thalidomide, and tragically the modern opioid epidemic. Patient safety really started to grab national headlines back around the turn of the century when the Institute of Medicine published To Err Is Human, which suggested that medical errors posed a graver threat to lives than car accidents or breast cancer or HIV/AIDS. The science in this report was terrible, and there were all sorts of problems if one analyzed it. And in this one analysis, they point out that medical errors are never excusable, but we need to approach them scientifically and not falsely attribute causality and recognize that ultimately every human patient dies. Fast forward 15 years, I was driving to work, drinking my coffee from my travel mug, and NPR reported that the BMJ is now announcing that up to 400,000, right, an order of magnitude greater than the IOM report, Americans are dying from medical errors. Well, the science is so bad in this paper that I hesitate to call it science, including they're extrapolating from studies with an N of 3 patients. How do we determine what is a death attributable to medical error? And what if I say patient X has received an extra dose of prophylactic Lovenox that was meant to be held, and her GI bleed worsens and dies? Did this patient die of a medical error? But by the way, the patient's a 98-year-old female with end-stage pancreatic cancer, inflorid sepsis, and DIC with ongoing GI bleeds and multi-organ system failure. Is that dose of Lovenox really what killed her? I sometimes try to get my staff to focus, instead of patient safety, I'm a fan of the idea of hospital safety. Number one, because everyone in a hospital needs to be kept safe, not just patients. And also there may be processes where there's no patient directly involved and they need to be safe as well. Are hospitals safe places? I would argue that they're not. And this is gaining increasing attention, and there's now a disease named after hospitals. This is a post-hospital syndrome. Identified by Dr. Krumholtz from Yale. where he points out a number of the risks of being hospitalized. And this is even before we get to patient safety or medical errors. Are emergency departments safe? Well, that's a good question. There really is a paucity of data. Anecdotally, I think we would all acknowledge that there's a level of chaos and noise in the ED. And for example, one recent study showed that following 17 nurses over 28 shifts, there were 178 medical errors. So in closing, listen, I believe hospitals are dangerous, patient safety matters, we need good science, and we need to continue to prioritize patient safety. Thank you.
Hi everyone, my name is Quentin Reuter. I work at SUMA in Akron, Ohio. Today I'm excited to have the opportunity to discuss a challenging neurologic emergency and specifically its misdiagnosis in the ED. We're going to discuss 3 different cases, each initially misdiagnosed, and while the 3 cases have varied presentations, they have a unifying diagnosis. After I present the 3 cases, I'll give you a chance to ponder what the mystery diagnosis could be, and then we'll end with a brief discussion on the topic. Case number 1 is a 60-year-old female who presents with altered mental status. She was at a bus stop when she abruptly lost consciousness and was witnessed to have a seizure. She's confused and only intermittently following commands and not speaking. The rest of her workup is unrevealing, however, so she's admitted with altered mental status. Case number 2 is a 57-year-old presenting with dizziness and imbalance. He has right beating nystagmus and significant difficulty walking, but after meclizine is feeling better and wants to go home, so is discharged with vertigo. Finally, case number 3 is a 53-year-old man presenting to the ED with ongoing vertigo since the previous day. His vital signs and neurologic exam are intact, but on CT of the brain, they notice subacute cerebellar infarct. He's admitted for further workup and neurologic testing. But then later that next day, he has abrupt loss of consciousness and suffers a seizure. The neurologist who witnesses the event suspects status epilepticus and treats the patient with benzodiazepines. An emergent EEG is ordered, but it is normal. The patient's persistently confused after the event. So those are the 3 cases: altered mental status, vertigo, and seizure. And as I mentioned, they all have a unifying diagnosis. I will give you a second to consider what could be going on. And if you're wondering, the image on the slide is meant to give you a hint. Let's start with case number 1. The next day, the neurology team evaluates the patient and note that she has no spontaneous language and a slight left gaze preference, as well as a right arm pronator drift. An MRI is emergently performed and she's diagnosed with an acute left MCA infarct. We regularly hear about stroke mimics or pathology that appear to be stroke on presentation, but are not, such as migraine or hypoglycemia. But what I want to focus on today are stroke chameleons, aka strokes that are misdiagnosed on initial evaluation. Patients presenting with aphasia without frank weakness represent a common stroke chameleon, often diagnosed as altered mental status. The aphasia can be subtle, especially if the patient has difficulty with initiation or ideation of speech. The key is in our patient is to complete a comprehensive language exam in all altered patients. Case number 2, the patient returns to the ED later that day with worsening headache and severe difficulty ambulating. An MRI ordered shows an acute infarct of the right cerebellum. Vertigo caused by stroke is another easily missed stroke chameleon. This is a nice systematic review describing patients with acute vestibular syndrome caused by cerebellar stroke. Roughly 80% of stroke patients have another focal deficit present on exam, and over half have severe gait instability. This underscores the importance of doing a thorough neurologic exam as well as assessment of gait. Finally, we hear a lot about the HINTS exam. This is the original study, and I just wanted to point out the importance of the head impulse testing, which tests the vestibular reflex. It is a main driver of the great sensitivity and specificity of the HINTS exam. Finally, case number 3, hours after the seizure, the patient woke up with right hemiparesis and gaze limitation. A CTA of the head shows a basilar artery occlusion, and despite thrombectomy, the patient ultimately remains debilitated and mute. Basilar artery occlusions often lead to terrible neurologic outcomes, with over 80% being severely disabled or dead at 3 months. This is a review of nearly 300 patients with basilar artery occlusions, and almost a quarter had convulsive life movements on presentation. Here's a table of other signs and symptoms of basilar artery occlusions, but the hallmark I want you to remember is acute onset of reduced consciousness. So how common are stroke chameleons in the emergency room? This paper here reported on over 400 consecutive stroke patients and found that roughly 20% were initially misdiagnosed. Symptoms such as lethargy, disorientation, dizziness, syncope, seizure, and difficulty ambulating are all associated with a greater likelihood of misdiagnosis. A 20% miss rate is relatively high. This is a similar study that found that only 2% of strokes are missed. It's tough to say what the true miss rate is, but I think the important take homes is to be careful with patients with non-traditional stroke symptoms. In closing, strokes have a multitude of clinical presentations and at times can be very difficult to diagnose. Subtle aphasia, vertigo, and acute onset of altered mental status all represent high-risk presentations that require a thoughtful approach in consideration of stroke. Just want to say thank you for the opportunity to discuss this topic with you, and best of luck catching chameleons in your own practice.
Hi everyone, my name is Victor Huang and I'm an emergency medicine and sports medicine physician at New York Presbyterian Queens. I'm the orthopedic and sports medicine director for our emergency medicine residency program. Today I'll be speaking about a classic orthopedic emergency, knee dislocations. I have no financial disclosures. Now, a knee dislocation should not be mistaken for patellar dislocations, in which the patella is displaced from the trochlear groove. A true knee dislocation is the disarticulation between the tibia and the femur, which is a limb-threatening emergency. Although they are rare and account for less than 1% of all dislocations, the incidence is likely underreported because 50% of all cases are reduced before arriving to the ED. So, as emergency providers, we need to look out for these occult knee dislocations because they have the same risk for complications. The most severe of these complications is popliteal artery disruption. The popliteal artery is tethered down above and below the popliteal fossa, making it relatively immobile and prone to injury. Meanwhile, the stability of the knee comes from the strength of the ligamentous support, with the anterior and posterior cruciate ligaments and the medial and lateral collateral ligaments. Dislocations usually only occur when 3 of the 4 ligaments are disrupted, although rarely, bicruciate injuries can result in dislocations as well. This usually requires high-energy mechanisms like MVCs and sports injuries. However, obese patients with a BMI above 40 can even dislocate with minor trauma, like a ground-level fall. Of course, no orthopedic talk would be complete without discussing classification systems. First, we have the Kennedy classification, which is based on the direction of displacement of the tibia relative to the femur. Anterior dislocations are the most common and can cause common peroneal nerve injury and intimal tears of the popliteal artery. Posterior dislocations are the second most common and have the highest risk for a complete tear of the artery. Less commonly, you have the medial, lateral, and rotational dislocations. The Schenck classification is based on the ligaments that are disrupted, and it can account for reduced dislocations as well as associated fractures. When evaluating traumatic knee dislocations in the ED, we need to first rule out life-threatening emergencies before addressing the obvious orthopedic injury. A good neurovascular exam should be performed, and any vascular impairment should be reduced immediately. On your exam, look for swelling, ecchymosis, and obvious deformity, but be wary of spontaneously reduced knee dislocations that can be easily missed without a good ligamentous exam. So assess for instability with hyperextension, valgus and varus stress, anterior and posterior drawer, and the Lockman test. Next, you should get AP and lateral radiographs to confirm the type of dislocation and look for associated fractures. Make sure you provide adequate pain control and sedation before you attempt the reduction. One provider applies longitudinal traction and gentle manipulation to the tibia, depending on the direction of the dislocation, while the other provider applies countertraction at the femur. Afterwards, you can use either a knee immobilizer or a long leg posterior splint with approximately 15 to 20 degrees of flexion, which prevents posterior subluxation of the tibia. If the post-reduction exam shows any hard signs of vascular injury, the patient should go straight to the OR with vascular surgery. A delay in the arterial repair can result in a 90% amputation rate after 8 hours. A CT angiogram or duplex ultrasound should be performed if there are any soft signs of vascular injury or an abnormal ankle brachial index. But even if the ABI is normal, the patient should still have serial vascular examinations for 24 to 72 hours because subtle intimal tears can be missed. Orthopedics should be consulted immediately for compartment syndrome, in which fasciotomies should be performed, and open dislocations that require irrigation and debridement in the OR. Lastly, be wary if you see this dimple sign, which is indicative of an irreducible posterior lateral dislocation that has significant risk for skin necrosis and requires open reduction. Remember that knee dislocations are not going to be always obvious like this one. So have a high index of suspicion when there is a concerning mechanism and multiligamentous instability. Palpable pulses are not enough. These patients need ABIs and serial vascular checks. Time is crucial, and delays can lead to irreversible limb ischemia requiring amputation. Now, you'll be ready to treat the next knee dislocation you see in the ED. Thank you for your time. I hope you've enjoyed this quick talk on knee dislocations. Do we have any questions?
This patient is alone in your ED. She doesn't remember what she ate for breakfast or why she's there. She doesn't perform any ADLs. I'm showing you a picture of a 3-year-old, but really I'm describing a 93-year-old, frail, cognitively impaired older adult. We recognize our 3-year-old is vulnerable, but really our 93-year-old, I think, is even more vulnerable. Today, I'm going to share with you a geriatric toolkit that will help you recognize subtle emergencies in your elderly patients. My name is Jessica Stanich, and I'm an emergency medicine physician in Rochester, Minnesota at Mayo Clinic. I'm going to share with you 5 tools. Number 1, the phone. Number 2, EKG and troponin. Number 3, CT. 4, your hands. 5, identifying goals of care. First, tool number 1, the phone. Call family, nursing homes. They have valuable information. Many times we accept that we have less information and test broadly in our cognitively impaired adults, but their families and nursing homes have important information. You don't have to call yourself. Share the load with your team. Improved communication has been shown to improve outcomes. Call primary providers during daytime hours. Tool number 1, the phone. Tool number 2, EKG and troponin in the undifferentiated geriatric patient. Patients with acute coronary syndrome who are elderly have higher mortality and present with atypical symptoms. Pay attention to black bars here comparing post-MI patients with life expectancy from CDC data, median survival in years versus age. They have high mortality. Geriatric patients presenting with acute coronary syndrome and atypical symptoms have even higher mortality. They don't present with chest pain. Tool number 2 is EKG and troponin. Tool number 3, CT, 2 scenarios, trauma and abdominal pain. Objective measures are less reliable, and the mechanism of injury often does not correlate with the severity of illness. First, geriatric trauma, low mechanism, high risk for injury. Physiologic markers are insensitive. 2 scenarios, falls and rib fractures, where CT can help you identify subtle emergencies. This data is from Olmsted County in Minnesota. Falls resulted in more deaths than any other unnatural cause. The mechanism of fall is misleading. Have a low threshold for CT in elderly patients who fall. Rib fractures, chest x-ray, 50% sensitive. For each rib fracture, mortality increases by 20%. Pneumonia increases by 30%. Low threshold for CT and trauma. Next, abdominal pain. Operative rates are 30%. Mortality 10%. Your exam is often benign. Tool number 3 is CT in abdominal pain and trauma. Tool number 4, your hands. Reassess, re-examine. 2 situations where your re-examination is vital. 1 in patients with altered mental status and 2 at discharge. Re-evaluating your patient with altered mental status may identify delirium. 30% mortality. The disease is missed 80% of the time and fluctuates. Next, at discharge. Pick up the phone again, communicate, coordinate care, ambulate. Ambulate at the end of your visit may identify more frailty that results in coordinated care after discharge. Tool number 4 is your hands. Tool number 5, goals. The subtle emergency is tailored care to patients' values. Aggressive symptom management is an emergency. Inquire at presentation. Symptom management prolongs life. 5 tools to help you identify subtle emergencies in the elderly. Tool number 1, the phone. 2, ECG troponin. 3, CT. 4, your hands. 5, identify goals of care. Question: which of the following tools can be used to help recognize subtle emergencies in elderly patients? The phone, ECG troponin, provider hands, or all of the above? Thank you.
Hi, my name is Dan Keller. I'm a second-year emergency medicine resident at Virginia Commonwealth University in Richmond, Virginia. And today, I'm going to be talking to you about performance-enhancing shrubs. All right, so picture yourself walking into a shift. You got lights flashing, alarms sounding, patients screaming at you, and it's a crazy place. Emergency medicine is unlike any other specialty. It puts unique demands on physicians to rapidly accumulate, interpret, and report information in a stressful and constantly changing environment. And although this pace, variety, and pressure are why we signed up for this life in the first place, these are also the same reasons why ER physicians are prone to errors and burnout. Let's touch on just a small part of your shift responsibilities. You're constantly reading EKGs and x-rays, getting interrupted by calls about EMS transfers and critical values, and monitoring vital signs for instability. Cognitive psychologists have fancy names for all these skills. Comparing new and old EKGs or chest x-rays to see if that left bundle branch block or chest opacity is new requires retaining and manipulating short-term information in a skill called working memory. Stopping what you're doing to answer EMS transfer calls or calls from the lab about critical values and then picking up where you left off is an interruption management skill called attentional control. And constantly monitoring vital signs, like watching to see if your tachycardic patient becomes hypotensive, taps into an ability to recognize new changes in a skill called vigilance. All of these things fall under a larger umbrella concept that cognitive psychologists refer to as directed attention. Directed attention is effortful focus that we concentrate on the tasks at hand. Think of it as your attention span, and like so many of us admit to, ours are pretty short. They're short because directed attention can fatigue and tire out. And when we tire out, that's when we become prone to errors and mistakes. Luckily, there's another type of attention called involuntary attention. Referred to as fascination, this is attention that's captured, not focused. There's no effort involved. And here's the kicker: engaging involuntary attention gives our directed attention a chance to restore. This theory of two different types of attention, one focused, one restorative, was creatively dubbed, you guessed it, attention restoration theory. Back on our imaginary shift, you have your focused, directed attention on the left and involuntary attention on the right. With each new task, your directed attention takes a hit, making you prone to mistakes. But if there was a way to hack into involuntary attention, this would give our directed attention a chance to recover. Smarter people than me have researched how best to hack that involuntary attention. And in a win for conservationists and Instagram photographers who post everything with #NoFilter, nature was found to be particularly powerful at capturing involuntary attention. To back this up, studies have shown that participants who completed an attentional test, then walked through nature before retaking the test, performed significantly better on the retest than those who walked through downtown or urban environments. Understanding, of course, that you can't just up and leave during a shift to take a casual stroll through your local park, my solution is simple. Just plant a ton of trees in your department. And now you have a forest. If that's frowned upon too, I have another option. The same crew from the last study did a follow-up demonstrating that simply viewing nature images briefly on a computer would improve retest performance compared to those who looked at urban images. So while there's quality research looking into shortening shift lengths and minimizing on-shift interruptions as a way of reducing ER error and burnout, I wanted to take this time to show you why we're susceptible to that error and burnout in the first place. Our responsibilities demand attention, which is a finite resource, and when it runs out, that's when we become prone to mistakes. Taking short breaks just to look at pictures of nature on a computer can capture your fascination and keep you sharp moving forward. Try it on your next shift. Take a quick break, bring up Google Images, and go to your happy place. This is a minimally invasive intervention that gives your directed attention a chance to recover and gives you a chance to improve your performance in the emergency department. Thank you so much for your time and attention. Ha! Get it?
Hello, my name is Alana Darling, and I'm going to talk today about addressing microaggressions when they come from the patient you are caring for. I have no financial disclosures. I do just want to acknowledge that I inevitably approach this subject through the lens of my own experience. The topic of microaggressions has gotten a lot of attention in recent years, and much of the important work has, for good reason, focused on microaggressions between colleagues or within professional relationships. But not all microaggressions occur within these professional bounds. On a regular basis, many of us are on the receiving end of some of these comments or actions by patients. These interactions are complicated. The doctor-patient relationship is unique and different from other client or business relationships. There's an innate power imbalance and also a moral and legal sense of responsibility on the part of the physician. Whether and how to respond is therefore not always clear. There are certainly benefits to directly addressing the microaggression in the moment. Often the patient doesn't realize that something they've done or said can be harmful, and addressing it can start or continue an important dialogue that is often entirely avoided. On the other hand, there are real barriers to confronting patients about microaggressions. By definition, these are frequent. While some could be at least partially addressed relatively quickly, others may take more time and effort. This is time and energy that could otherwise be spent caring for patients or doing other work and can represent a significant tax on the provider. In addition, the provider may feel a pressure to preserve the doctor-patient relationship at all costs and may fear the effects that confrontation could have on this relationship. This is heightened even more if a lot of value is placed by an institution on patient satisfaction surveys and complaints. And to be fair, when we meet patients in the emergency department, they are often sick or in pain or worried. In this context, we might at times let more slide with patients than we would, say, a colleague. But leaving these microaggressions unaddressed is also not ideal. This might make the behavior more likely to continue, thus perpetuating the problem. So as we analyze these interactions, there are numerous factors to consider. First, there are patient factors. Clinical status is important. If the patient's unstable, it's probably not the best time to get into it. If they're incapable of participating in a meaningful conversation, most of us would also let that go for the time being. Then you consider the patient's characteristics. What background and what type of privilege might they be bringing to the interaction? Where is this behavior stemming from? The provider's characteristics are obviously important. What features are being interpreted or misinterpreted by the patient? Are there intersections of race, gender, ability, age, and more that contribute to the context of the interaction? We should also consider the level of training of the target of the microaggression and the power dynamics at play. A trainee or student may be less likely to speak up in defense of themselves when they are in a group of more seasoned colleagues. The level of severity of the interaction will affect response. Some of these are not so micro, and the more blatantly discriminatory they are, probably the more likely we are to speak up. That's not to say that the more subtle microaggressions are not harmful or worthy of response, just that they may require a more nuanced reaction. So considering all of these factors, what are some ways we can respond? Well, first consider individual responses from the target. These are going to vary according to the factors we just reviewed, and will also likely be affected by the personal values of the provider, as well as their judgment of the time and energy required to respond. Sometimes a very brief response is possible before moving on. Other times, addressing the microaggression may require simple but direct corrections or questions to the patient asking them to analyze the assumptions or privilege behind their behavior. A response from a bystander or team member can be particularly important, especially in instances where the microaggression goes unaddressed with the patient, or in cases where the target may not feel completely in control of the interaction, for example, with a student or trainee. Oftentimes, a simple acknowledgement of the situation goes a long way. Letting colleagues know that they have your support can make for a safer workspace, and team leaders openly discussing microaggressions with trainees can send the message that A, it's okay to talk about this, and B, they have the support of the team. And lastly, there are some more systemic or institutional level responses that are possible. No institutional changes are going to prevent providers from experiencing microaggressions, but institutions should protect and support employees who do decide to address these with patients, and they should use caution in interpreting and applying patient satisfaction surveys and complaints in ways that may have professional or personal consequences. Programs can utilize anonymous reporting systems to get a sense of the quantity and nature of the microaggressions employees face, and they can continue to train and educate all employees on appropriate bystander reactions. Ultimately, prioritizing a diverse physician workforce and diversity in leadership is critical to creating a more meaningful and sustained culture shift. Thank you very much.
My name is Gail Kuklis, and I would like to talk to you about 2020, my year in N95, the year dedicated to the patron saint of emergency medicine, Miss Rona, and our relationship with the changing climate. I would begin with a review of the N95 mask options, then transition to the use of these masks in the context of infectious disease, wildfires, and lastly as a contributor to healthcare waste. There are no conflicts of interest. 2020 was the year dedicated to the healthcare system becoming a style icon. The global fashion community took it upon themselves to design iconic pieces, including this beautiful $1.5 million diamond-encrusted N99 mask by Yvel. Myself, I like to reminisce about the before times. I think fondly of my first N95, the 1860S. It's not very comfortable and it gives me terrible mask acne, but I got the job done when all I needed to do was briefly see a TB rule-out patient and throw it away. My personal favorite, the 1870. We had these briefly at the beginning of the pandemic, and due to the soft, malleable nature of their construction, the supply was rapidly depleted. I am happy to report that they have resurfaced and have returned to my regular rotation. In the interim between 1870 spikes, I relied heavily on the duckbill. This too is a rather comfortable option. However, the elastic straps tend to tangle in my hair more often. I did have a patient tell me how much she liked the mask because it made me look like a duck, so I think it did wonders for patient relations. The poor air quality did not deter me from my runs that have helped me maintain my sanity. Instead, I found the 8511, a cloth-lined mask with an exhalation valve that is definitely not appropriate for patient care, proved to be the answer. The elastic straps are material more like a hair tie than a rubber band, also contributing to the overall comfort of the mask. This year, we were introduced to Miss Rona. She has allowed me to expand my taste in N95s and has helped us to see and feel the many shortcomings of our healthcare system. We will continue to experience climate-related stresses to our healthcare system and confront new challenges brought on by the climate crisis, a slow-motion version of the pandemic. As such, the N95 became more than a style icon for me. It's become a symbol of climate change and new opportunities for emergency medicine. To me, it represents a complex relationship with infectious disease, wildfires, and healthcare waste. The growing frequency of intensity of climate-related extreme weather events has led to displacement of large groups of people. One study from Brigham and Women's Infectious Disease Department showed a 400% increase in frequency of disease outbreaks and forcibly displaced peoples, including measles, chickenpox, TB, and cholera. About a third of these disease cases in the 20-year study would benefit from an N95. Independent of human displacement, the changes in the environment following extreme weather events can transiently increase availability of habits for vectors or the infectious organisms themselves. For example, following the Pakistani megafloods of 2011, an estimated 37 million presentations for various infectious illnesses were reported in the following year. Similar to the changes following extreme weather events, climate change allows for long-term habitat changes. These changes will lead to frequent changes in endemicity of vector-borne diseases. While the pandemic was my primary interaction with N95s, the California wildfires this year were also rather spectacular. Much of the summer and fall in Fresno, the air quality index was greater than 150, which is unhealthy, especially for vulnerable populations. The total land consumed by the fire is daunting, but dwarfed compared to its resulting smoke cloud. Climate destabilization continues to worsen the wildfire seasons in a multitude of ways. The prolonged fire window was particularly of note for us this year, as California shares many of our resources with Australia. Because of the long season for both places, our seasons overlap significantly, leading to resource shortages. The wildfires have the obvious destruction to people and property. Our hospital felt this directly with multiple critically ill burn patients arriving nearly simultaneously, and we're a well-resourced burn center. Further loss of property and displacement lead to long-term mental health effects and can be complicated by infectious disease outbreaks. The air particulates released during fires can lead to exacerbations of underlying cardiovascular and respiratory illnesses. And finally, wildfires emit high levels of carbon dioxide that contribute to rising greenhouse gas emissions, further fueling the climate crisis. And while at the beginning of the pandemic, I was a mask hoarder for the fear of running out of PPE, I've finally begun throwing out some of the masks. Here I became conflicted again, remembering the significant amount of waste that created by the healthcare system. Thankfully, in that initial anxiety of our PPE shortages, the healthcare system took a moment to learn to recycle. The soft, comfortable, reusable cloth gowns made appearances at many hospitals, and we had a bin by the door to collect masks for reprocessing, though I don't believe anything ever came of this. We've known for years that the reusable isolation gowns are well worth the investment. Studies done at UCLA show no difference in liquid permeability of these versus their disposable counterparts. And over the course of 3 years following the transition to reusable, the institution saved about $1 million. The pandemic has required us to rethink how we provide care to our patients. It has underlined health disparities that will continue to be borne out as the impacts of climate destabilization become more obvious in our interactions with patients. It has also shown us that we can be more flexible and move towards safer and more equitable practice patterns that can lead to the change of health for our patients and lead the change for health for our patients.
Hi everyone, my name is Kevin McGurk. I'm a resident at Cook County and my talk today is titled A Brief History of Electricity, the Evolution of Defibrillation, Cardioversion, and Pacing. I'd like to begin with some acknowledgments. First off, my co-resident, Dr. Stephen Cooper, he's pictured there on the left, who helped with some of the research for this. I'd also add that this talk could have alternatively been titled Creepy Old Men Performing Weird Experiments on Animals. So I'd like to thank all the animals that contributed to science. Takeaways for this talk. First off, electricity is very cool. Second, the path to advance is usually very strange. And finally, we are almost certainly doing something now that future generations will find very, very stupid. So this talk begins in about 3000 BC. In that era, ancient civilizations were capturing electric fish and using them to shock one another as an effort to treat conditions like arthritis, migraines, and gout. Not a lot of advancement happens then, all the way up until 1740 with the development of the Leyden jar. With that advance, we could store an electric charge in a jar and use it for experiments. Almost as soon as it had been developed, scientists began shocking small animals. Franklin liked to shock small turkeys. The next big change came in the 1780s and 90s when Galvani and Volta, who were practicing in Italy, made all sorts of advance with the way that electricity affects our normal physiology. Galvani showed that a shocked frog leg would move. Volta took that and led to the development of the first battery. Galvani had a nephew named Aldini, who was a very strange guy, took the experiments a lot further and began applying electricity to executed prisoners in London. Word of his experiments got to Mary Shelley and actually were the inspiration for Frankenstein. There were a lot of weird things going on during this era trying to revive patients, including running electricity from mouth to anus. That did not work. Perhaps unsurprisingly, given the zeal of the Galvanists of that era, trying to shock anything that would fall and anyone that would die in all kinds of weird ways, there were people of the era who would sew labels into their clothing requesting that no electricity be applied to them if they fell ill or died. It was effectively a rough precursor to today's DNR. The next big advance in science happened in the 1840s. That's when Waller developed the first EKG. He demonstrated it on his dog Jimmy, there on the left. His required leads on all four limbs and one in the mouth. Eindhoven improved upon that to an EKG closer to what we would see today. That's his first machine. In 1882, this woman was taken care of in Prussia and contributed a lot to our understanding of cardiac physiology. She had a chest wall tumor that was removed and a thin layer of skin that allowed for her heart to be visualized. They could then compare that with EKGs that were being done at the time. In 1899, ventricular fibrillation is described, including that it can be induced with low voltages and larger voltages in animals could stop it. That isn't applied for the first time in humans, though, until 1947, when Claude Beck, a surgeon in Ohio, has a 14-year-old undergoing an elective case that surprisingly arrests. He performs manual compressions of the heart and then busts out this experimental machine pictured there, including the metal spoons he used to actually defibrillate the heart, and it worked. By the 1950s, they'd improved upon this process, and in 1955 was the first successful transthoracic defibrillation. Machines kind of continued to improve and looked like the ones there on the right. In 1932 was the first attempt at pacemakers. Albert Heyman developed the first one. Lots of limitations, including the fact that it relied on a transthoracic needle and wire, so this was running through the chest. Also not very portable. He was met with significant skepticism in that era. There were many portability problems that scientists were confronting, and so a transient solution that was described in the era was to use percussion or fist pacing Instead of shocking, people would punch the chest rhythmically if they had symptomatic bradycardia. In 1957, we developed an improved pacing, but unfortunately still portability issues. That machine was dependent on wall electricity, a famous example of a hospital losing electricity briefly and a patient dying as a result, compelled companies to develop a more portable version in 1958. The first implanted pacemaker was done in 1960, and the first implanted AICD was done in 1980. So we're continuing to get larger and larger strides for bringing us closer and closer to contemporary medicine. In 1966, the National Highway Safety Act, 1973, the EMS Safety Act helped to create EMS like we imagine it today, the AED in 78, and then monophasic to biphasic waveforms in the 1990s made for more portable and lighter machines. Today, there are more than 3 million AEDs in the United States. More than half the American workforce have access to an AED at their jobs. And out-of-hospital cardiac arrests have almost 2-time improved survival if there's an AED present. And I'd like to thank everyone for taking the time to listen today.
Hi, my name is Mike. I'm from Boston Medical Center, and I have no disclosures. Today, I'm going to convince you that phenobarbital is the treatment of choice for alcohol withdrawal syndrome because it's safe, effective, and easy to use. Now, you're probably wondering, what's wrong with benzos? But stop me if you've heard this story before. You give a patient in withdrawal 4 milligrams Ativan IV, which promptly puts them to sleep. By the time you get back to him, he's withdrawing again, so you give a lower dose. After getting pulled away to see other sick patients, you're called back to find him agitated, delirious, and ripping out his IVs. You missed your window. But it's not your fault. We've all been there. We've all missed that window. Why? Because there is no window. Benzos have an unpredictable dose response requiring frequent reassessment. A given dose might not touch one patient's withdrawal, but cause respiratory depression in another. What about efficacy? Not only are benzos unpredictable, they don't always work. There's a well-described phenotype of withdrawal that is resistant to even incredibly high doses of benzos. Finally, benzos require frequent redosing. With symptom-based treatment, patients ride the benzo roller coaster up and down, often over and undershooting the appropriate level of sedation. There has to be a better way. It's time to turn off your tracking computers. Stop mindlessly dosing benzos and move into the future. Embrace the elegant solution of phenobarbital. First and foremost, phenobarb works. It's universally effective. Unlike benzos, there is no evidence of phenobarb-resistant withdrawal. In fact, those patients with benzo resistance, they respond rapidly to phenobarbital. Phenobarb is predictable with a narrow therapeutic range of 5 to 20 mg per kg. Compare that to the cavernous range of benzos. It gets better. Phenobarb has linear pharmacokinetics that are well described. When we give a dose of phenobarb, we know exactly how much ends up in the patient. Now, you're probably saying, this is great, Mike, but doesn't phenobarb cause respiratory depression? It does, but only at very high doses. We're aiming for a max dose of 20 mg per kg, literally half the dose that would cause respiratory depression. What about intubations? I know it's on your mind. Compared to benzos, phenobarb decreases the risk of intubations in patients with alcohol withdrawal. How about dosing? With phenobarb, you can set it and forget it. The dose can be gently up-titrated over many hours. After that, it will auto-taper all by itself. Phenobarb is great, but like all medications, there are areas where we need to use caution. Phenobarb and benzos act synergistically. When given together, they can cause respiratory depression at lower than normal levels. Once you start down the phenobarb pathway, no more benzos should be given. Phenobarb interacts with other medications, In particular, it can inactivate antiretrovirals, potentially harming an already vulnerable population. So, how do we put it all together? Here's how I would approach the patient we discussed earlier. Give a full load of 10 mg per kg. Run that over 30 minutes, not IV push. Symptoms still not under control? Give a rescue dose of 2.5 to 5 mg per kg. You can continue giving rescue doses up to 20 mg per kg. At that point, if you still don't have symptom control, you need to consider alternative or concurrent diagnoses. We owe it to our patients to be familiar with phenobarbital and use it appropriately. The next time you see a patient in withdrawal, don't give in to the dark side. Start with phenobarb, a more elegant medication for a more civilized age. Thank you.
Crowds can be remarkably unwise, particularly on complex subjects where the stakes are highest, like a pandemic. Like the historian Thomas Carlyle once said, quote, "I do not believe in collective wisdom of individual ignorance." But what if I told you the wisdom of crowds works? In situations, for example, like this one, we're all stuck in traffic and subconsciously we read the driving behavior of others around us to get us out and get an escape route. Well, as COVID erupted in the spring of 2020, we found ourselves in new uncharted territory as emergency physicians with COVID cases spiraling out of control. Data available to us in small pieces on how to deal with the pandemic at hand. Like being in an open field, we could see the storm coming, watching as we have nowhere to run, no shelter above our heads, wondering how are we going to treat the world's sickest patients, whether it's using a CPAP machine or a ventilator. Knowledge had to be crowdsourced. So what did? We relied on each other. We used the wisdom of crowds to help us escape uncertainty. We worked as teams to deal with remarkable complexity and perhaps make better decisions in the emergency room. Because in theory, groups can make better decisions. As the saying goes, if two people always agree, one of them is redundant. Diversity of opinion can lead to open-mindedness, and we can decentralize and be completely free of pressure to think on our own. We have evolved from telegraphing radio waves in World War II to sharing digital media with the tap of a screen. Our coping mechanism for the absence of data from randomized control trials has been linked now to Twitter accounts and case reports. Can you imagine if the wisdom of crowds was available back in the old ages, where instead of using horse and buggy, we could share information with each other online and through other venues? Now, what if I also told you that the wisdom of crowds can unmask uncertainty? This study is one example from the LSE, showing real evidence that for COVID, the intensity of Twitter tweets per region was able to forecast the severity of COVID-19. Look here at the regions of Italy, Spain, and the US from January through March. X-axis is time, Y-axis number of users discussing COVID on Twitter, and the intensity of COVID Twitter activity identified the localities most affected by the pandemic. And for the United States, for example, in the same paper, the cumulative number of deaths 1 month forward on the X-axis on April 14th was linked to the mean tweet intensity at the initial peak in early April on the Y-axis. Trends in public opinion show evidence of collective intelligence, even in politics and other areas. The wisdom of crowds can actually successfully forecast polls better than objective data. But our culture does have significant barriers to overcome. We're all trying to identify an answer with our cognition. We don't always synchronize our activities with others, and we also don't act together with our own self-interests at hand. But we're now seeing that specialty organizations in emergency medicine like ASAP are trying to curate social media-based discussions to create resource guides. On March 4th of last year, Engaged was a communication hub that was created from joint discussions online. And as you can see here, there were membership numbers from across the world and even the United States, with the largest number from March 10th to March 18th, right when the first peak really started to begin. We can see members coming together curating information, which eventually helped create a field guide that included treatment options and ways to handle special populations. But collectively as a society, we still face some serious challenges. How are we going to stay organized? How are we going to ensure content is accurate and verifiable? How are we not going to polarize others and exclude those who don't have access to technology or broadband? And how can we provide true insight when the stakes are so high? Because I can tell you that COVID-19, as you know, is not the first pandemic, and it won't be the last pandemic of the 21st century. So we have to develop efficient, stable, timely communication models moving forward. As my favorite jazz saxophonist John Coltrane once said, one positive thought produces millions of positive vibrations. And even though our thoughts aren't always positive during a pandemic, our ability to make noise has no ceiling. So I want to thank you for your time and for all that you're doing for your communities. It was a pleasure speaking with you today. Thanks.
Hello, hello. Hi, my name is Dr. Joshua Ellis. I'm the current medical education fellow at Beth Israel Deaconess Medical Center and Harvard Medical School's affiliated program. And I will be addressing the elephant not in the room. We're going to talk about the sensitive subject of affirmative action in medical education. A bit more about myself. I'm actually half Black and half Mexican American, a descendant of an undocumented immigrant, and I grew up well below the poverty line. I'm also a proud member of the LGBT community, and I just wanted to make sure that all these biases were up front as we had a discussion about affirmative action. So first and foremost, no financial disclosures, but as I previously mentioned, I do have some obvious biases. I am half Black and half Mexican American. I am the first in my family to go off to college, and a picture here on the right is actually a picture of the household we spent a part of my childhood growing up in. The objectives of today's lecture are that we're going to talk about several key events and Supreme Court cases related to affirmative action. And we're going to talk about the racial demographics relevant to each of these events and Supreme Court cases. And then we'll also discuss current racial demographics relevant to medical education. Now here's a list of the historic events that we have to cover, and the highlighted blue are the Supreme Court cases. And we'll begin with the 1961 John F. Kennedy executive order, which first initiated affirmative action policies and the hiring of government employees, but also in the undergraduate and medical school enrollment as well. And this was actually found to be quite effective. And the underrepresented minority enrollment in medical school went from 2% to about 8% in less than a decade during the time frame that this was actions in place. And you can see the steep incline in this graph here, highlighted by the red circle. And we found this would actually falter off as court orders would find resistance and fight against affirmative action. So much so, it climactically resulted in a Supreme Court case decision in 1978, where Mr. Bakke sued the University of California Davis Medical School for racial discrimination. This Supreme Court case eliminated the racial quota system, but it did allow for the continuation of affirmative action policies. Now, at this time, UC Davis Medical School had 16 spots reserved as a quota for its minority applicants. And without this, only one Black student otherwise got into the program. And nationwide, about 6% of medical students were Black, and 542 Black men were enrolled at this time. Our next event is the 1990 AAMC project to enroll 3,000 minority students by the year 2000, which would double their number. And you can see another steep incline highlighted by the red circle in the enrollment of minorities in medical school. This was once again met with resistance when affirmative action legislation in the 90s, state by state, there was bans to affirmative action. And we can see a steep decline in the enrollment. Mississippi actually had a 64% decrease in their enrollment of minorities in medical school during this 5-year period. The Grutter versus Bollinger Supreme Court case of 2003 actually nullified the prior legislation and reaffirmed the affirmative action as a policy in the states. This was originally Barbara Grutter suing the Michigan Law School. And at this time, nationwide, JAM actually did a pretty great article with Dr. Cohen about affirmative action. If it were to be cut, 70% of minority applicants would also not matriculate. And this would leave only barely 3% of medical applicants as underrepresented minorities. The next Supreme Court challenge would be Fisher, Abigail Fisher, an applicant, and also Edward Bloom, a political activist, suing the University of Texas, primarily for its top 10% rule. The top 10% rule was that the top 10% of every high school in the state had guaranteed admission into the university. And you can see the statistics here. 7% of that would be African American, as noted in the red circle. And then without the top 10%, only about 3% were African American. And this was a good ability for the University of Houston to employ racial diversity. Nationwide at this time, of note, 515 Black men were accepted into medical school. And this was less than the 542 of 1978 that I previously mentioned. Students for Fair Admission versus Harvard was the next Supreme Court challenge, and this was alleging that it's discriminatory against Asian American applicants. And of note, I hope you guys can recognize that picture. Edward Bloom, a person who sued University of Texas, is actually the founder of the SFA. Also of note, Harvard's 2019 incoming class was 25% Asian. Although Asians did have the lowest acceptance rates of any race, of note, the incoming class was also 7% African American. I'm sorry, 14% African American. Now, the Students for Fair Admission once again upheld affirmative action, but there are more challenges to come. And the reality is, if we look at the current racial demographics of medical education, they're nowhere on par to reaching population parity. African Americans make up 13.4% of the country, and yet only 7% of medical students. And we have to continuously have this conversation regarding affirmative action. And what I would always recommend, if you're going to have this conversation, always start with the data. And that's what I hope to bring you today, is data regarding these major landmark decisions and events related to affirmative action. Thank you guys for coming to my talk. If you have any questions, please reach out to me.
First of all, I want to thank you, the audience, and SAEM for the opportunity to join this fun Ignite section. I'm Amanda. I'm a first-year EM resident at SUMA in Akron, Ohio, and I'll be talking about the language of addiction. As emergency physicians, we pride ourselves for being available 24/7, for caring for everyone who walks through the door, and for caring for every physical and psychosocial illness that affects our communities. With that in mind, I want you to reflect on this one question. What is the first thing that comes to your mind when you read this on your patient's chart? Drug abuser. Over 20 million people in the US suffer from a diagnosable substance use disorder, but less than 20% of them seek treatment. Stigma is the most common reason reported for not seeking care by people who perceive the need for treatment. Stigma against people who use drugs comes from the outdated belief that addiction is a moral failing. When we believe a bad stereotype, we automatically react negatively towards these individuals and support harmful policies. As physicians, we are not immune to this negative. Residents report more negative attitudes towards individuals who use drugs than towards those with severe psychiatric illnesses. With us, EM residents revealing the worst attitudes and negative bias in comparison to our specialties. While healthcare professionals report lack of training and support structures from the institutions where they work as barriers to care for patients with substance use disorders, they also admit to have low empathy and avoidance of such patients. Health workers report preconceived ideas that patients with substance use are violent, manipulative, unmotivated, and are draining the system. We also impose our beliefs on patients and often misattribute symptoms to substance use, resulting in poor communication and suboptimal care. How can we offset our own biases? Words are powerful. How we refer to people who use drugs is proven to shape our medical judgment and worsen negative stereotypes. Campaigns to decrease stigma advocate for person-first language that respects people's humanity by not defining them by their diagnosis. Here are some examples. For example, instead of alcoholic, we use person with alcohol use disorder. The biggest predictor of negative attitudes towards patients is perceived responsibility for their disease. Providers view drug abusers as more responsible for their condition and more deserving of punishment than someone described as having a substance use disorder. Evidence shows that words like substance abuser and addict are associated with negative words, elicit explicit behaviors in healthcare workers, including differential treatment options being offered, which results in poor quality care. On the other hand, terms like substance use disorder are associated with positive terminology on the same word association tests, empathic behavior, decreased stigma, and perception of people being deserving of treatment. Also, the simple positive depiction of individuals with substance use disorder makes the general public more willing to welcome them into their lives, as well as when someone is described as having a substance use disorder in comparison to a drug abuser. Due to the harmful impact of stigmatizing words, the DSM-5 replaced substance abuse with substance use disorder as a diagnosis, and the White House changed the language of addiction as a plea for a replacement of discriminatory language with scientific terms. The Recovery Research Institute developed a dictionary, which is a tool to avoid stigmatizing language in our professional discussions and documentation. Here are some examples. In summary, substance use disorder is one of the most stigmatizing and deadly illnesses, and its consequences affect over half of American families. Sufferers already have great shame, and it's our job to prove to our patients that we don't judge them by their illness. We don't refer to our patients of a high BMI as fat. Just as such, we should be intentional about how we talk about our patients who use drugs. Using disapproving words such as abuse or addict may reflect a value judgment or a bad habit. Although language alone may not eradicate our bias, there is strong evidence that carelessly spoken and written language leads to proliferation of harmful stereotypes and impartial care. Old habits die hard, but our words do matter, and I want you to be ignited. Our shared commitment to serve marginalized communities must fuel rapid adoption of verbiage that accurately portrays the science of addiction and respects. Thank you very much. Here are my references to the multiple studies from which I gathered information. I'd be more than happy to share with anyone who is interested and answer any questions that I may, with the caveat that I'm not an expert.
Good afternoon. My name is Dr. Monica Saxena, and I am thrilled to be here today to talk about allyship. Over the next few minutes, I will share a definition of allyship, explain why it's important for our residents, and give examples of how we can all be allies. In preparing this presentation, I put out an open call to our underrepresented minority colleagues. I was struck at how often certain words were repeated. It is these words that act as a clarion call to allyship. Allyship is when those with privilege and power help those without. It is important to note that privilege does not mean we haven't worked hard or sacrificed. Privilege just means that there are some things we don't have to deal with because of who we are. We need allyship because the realities of the outside world do not stop at the walls of the ED. This especially affects our residents who are underrepresented racial ethnic minorities, LGBTQ, and female. For example, recall the 2017 Muslim travel ban. Hundreds of those affected were physician trainees. Over the last few years, an increasing number of our fellow physicians have recognized that they have a role in advocating for our underrepresented minority colleagues. Physicians have marched in the streets and staged die-ins protesting gun violence. They have formed advocacy groups and published op-eds. Emergency medicine physicians have also been speaking up academically. In the last few years, an increasing number of our EM colleagues have conducted research and written both about diversity and discrimination they face as underrepresented minorities. Their titles alone further reinforce the need for allyship. As the words of our colleagues suggest, we should all be allies, especially to our underrepresented minority residents. In addition to being the right thing to do, we should all be allies because it ultimately is better for our patients. Diversity of all stripes benefits patients. For example, one study showed that when Black patients are treated by Black doctors, they have better cardiovascular outcomes. I'm not suggesting we only treat patients who share our identities, but rather that representation matters. As of now, we remain a relatively homogeneous specialty. With regards to trainees, less than 40% of current residents are female, and less than 13% of current EM residents are underrepresented racial or ethnic minorities. And our minority trainees need us as allies. Minority residents report fatigue from being the only one in their environment. Also, a study of 24,000 residents showed that residents of color and female residents reported relatively higher rates of bullying. We don't need diversity or inclusion in our job titles to practice allyship. Effective allyship happens with everyday actions. Here are 4 strategies you can start today. Amplify, include, champion, persist. Allyship Strategy 1, Amplify. When an underrepresented minority resident speaks, use your power to echo, attribute, and amplify. Prepare residents to effectively share their opinions in meetings. Amplify virtually. Include underrepresented minority residents in your social networks. Studies show that when you bring minorities into your social networks, you subtly signal the value of diversity and fairness. Allyship Strategy 2, Include. Include underrepresented minority residents in your research projects. More actively, include these same residents in your conversations around the ED. Role model inclusion to our ED team members. Allyship Strategy 3, Champion. Underrepresented minority residents often cite bullying by nurses. We have all witnessed this happen. Imagine the outcome if you as the attending simply said, "Please stop, that's not okay behavior." Being a champion doesn't have to be confrontational. For example, if a nurse consistently questions an underrepresented minority resident's orders, call the resident over and start a discussion between the 3 of you. Allyship Strategy 4, Persist. Sometimes it's not immediately obvious what we should be doing to support our underrepresented minority residents, yet we must continue to try. One method is to simply ask, "How can I support you?" Allyship also requires stepping outside of our comfort zones. My EM mentor is the exact opposite of me politically and personally, yet we bonded over a love of the outdoors. And during residency, other attendings also transcended identity politics to make me a better doctor. These allies are the reason I am speaking here today. As I finish my training and move on to a place where I can be an ally to our residents, this presentation and clarion call to allyship is my swan song to them. Thank you.
Good afternoon. My name is Carrie Camaseras. I'm a medical education fellow at the University of Michigan, and today I'll be speaking with you about the 7-letter F word, failure. Now, this is a huge topic with lots of nuance to appreciate in the clinical, educational, and professional realms, but today I have a singular goal. In the next 5 minutes, I hope to convince you all that academic emergency medicine would benefit greatly from normalizing, embracing, and announcing our own failures for the sake of our trainees, ourselves, and our field. Now, think back to your most recent failure, whether it was a rejected grant application or manuscript, a poor patient outcome, or a disastrous teaching evaluation. The sting of failure is familiar and almost feels built in to the academic emergency medicine experience. But now think back further to your first major professional failure. Maybe you didn't get into med school, failed a clerkship or a step exam, didn't get a job you were hoping for, or had your first devastating patient outcome. Do me a favor and hold on to that feeling for a moment. Now, as a student, resident, and even sometimes now, I often assume mistakenly that my mentors and superiors have had this nothing but upward professional smooth sailing with career trajectory smooth, painless, and one win after another. But that's not like real life. Turns out it's not true at all. Reaching out to several mentors, I learned that perhaps career trajectories are messier than I thought. And in hindsight, each of these bumps in the road, large or small, did not seem to permanently derail anyone's career. The key word there, though, being hindsight. The feeling at the beginning of a free fall is terrifying. How long will this last? When will we pull upwards? Is this old roller coaster going to burst into flames? The terror of an unknown trajectory is often accompanying the first major professional failure. This is the inflection point. After a major failure, we all have the option to tailspin, plateau, grow, or give up altogether. Many worry that their first major failure is a marker of a doomed career altogether. But is this true? Well, in 2019, a group analyzed the impact of setbacks in the career trajectory of young scientists, tracking several measures of long-term success relative to the outcome of their very first major independent grant application. To make the groups as similar as possible, they compared those who just narrowly missed and those who just narrowly qualified for funding in their very first applications, excluding the superstars and the underperformers. Think of it as comparing the Olympics bronze medal and fourth place winners. Over the course of 10 years observation, it was actually those who narrowly missed on their first grant application who outperformed those who narrowly won in several categories of academic achievement, such as total citations or number of hit papers. There was, however, a drawback. A larger amount of the early failure group left science altogether. Perhaps that early failure felt too much like the top of a roller coaster, with no clear view on how far they would fall. And perhaps they didn't have adequate support or mentorship to help them see the upward trajectory in the future. So what does this mean? Well, early failure does not undermine trajectory, except for those who walk away. As we help our trainees navigate their first major failures, one key component is the open conversation about our own setbacks. It's understandable to want to keep this chained off and have remaining anxiety. If we admit our flaws, will our trainees no longer look up to us? Or will our leadership finally see us as the frauds our imposter syndrome has convinced us we've been all along? Well, in popular culture, who do you root for? It's the underdog. The movie Rocky didn't take 1976 by storm because he won every single match. Honestly, that sounds like a terrible movie that nobody would watch. No, we rooted for Rocky because we saw him get knocked down over and over again, but never gave up. In 1998, in Cool Runnings, we didn't root for the perpetually winning German bobsled team. No, it was the scrappy underdogs we rooted for, as they overcame setback after setback, ultimately being appreciated as equals on the bobsled course. Dr. Haushofer of Princeton University took this advice literally, creating his own publicly available CV of failures, including schools where he'd been rejected, papers, jobs, and grants that he hadn't received. Now, in the spirit of this, I'd like to confess a few of my own most recent failures. I was super late turning this talk in and almost didn't do it altogether. In the first semester of my fellowship master's, I couldn't finish one of my classes because I didn't balance my classwork with new responsibilities. The fellowship research project I've been doing is shaping up to be quite negative. And very embarrassingly, I didn't really understand how to read the attending schedule at one of my clinical sites and failed to show up to my first attending shift ever. In the moment, each of these felt insurmountable, but with the benefit of hindsight, I now see them as small setbacks. I hope this talk has made at least one person, at least 1% more comfortable with embracing and announcing their own failures. Thank you very much.
Hi, everyone. My name is Brett Sitzler. I'm a third-year resident at Cleveland Clinic Akron General in Akron, Ohio. I'm here today to talk about medical innovation. The talk today is going to be titled, Let's Get Innovating. So why don't we get started? You walk into a shift to EMS unloading an unresponsive hypotensive patient into your recess bay. Fluids are hung, the patient is intubated, and someone looking through the patient's chart says, it looks like this patient has a history of alcoholism. During intubation, this is what you see. Blood in the airway. Alcoholism, hypotensive, and blood in the airway sounds like a varicose bleed. About this time, patient loses pulses. Compressions, massive transfusion, GI and MICU called, now what? She's still bleeding despite maximal medical therapy, and up walks someone with this. A Minnesota tube, thank God. As you pull it out of the box, ready to wield your new weapon in a battle, you realize you don't get the caps or stopcocks or hemostats. No, you get a tube. Oh, and you need a large syringe, maybe something from a Foley catheter, a football helmet from who knows where, and a manometer to make this work. Of course, you know where you can get a manometer, right where you left it the last time you checked the compartment pressure. And one of the highest mortality resuscitations you will ever be involved in, you have to be innovative to make this thing even kind of work. You see, you don't have to look far for areas of innovation in medicine. In the medical field, we have intelligent, creative people. I ask, why are we not innovating more? We need to reach for our inner child and explore. A mother was talking to her 3-year-old daughter when she showed her daughter a picture of herself from when she was younger. The mom was about 8 or so in the picture. She asked her daughter if she knew who this was, to which the daughter replied, yeah, of course I do. The mom said, well, okay, yeah, who is it? Well, that's me when I'm bigger. Children are unimaginably creative. They build rocket ships, sail the high seas, and fight monsters all before lunch. For children, the world is a network of possibilities, free of the constraints placed by conventional ways of thinking, like, say, a camera that can take pictures of the future. To the child, of course it can. Why not? As we age, we create the framework for how we should interact and perceive the world. And as a result, our creative capacities diminish. Let's take this question, for example. It asks us to determine the number of the parking space covered by the car. Now, see, cars are supposed to be able to read the numbers as they pull into the spaces. So when we rotate the question, the answer becomes instantly recognizable. It's 87. What I didn't tell you was that this question is taken from a first grade math test in Hong Kong. See, children have no problem answering these questions. But we are trained to read left to right and top to bottom. As adult innovators, we must strive to allow ourselves to flip something upside down and work on it wrong side up. As medical professionals, this seems very difficult. We're trained to operate deliberately based on known facts and variables. We're algorithmic, conservative, and methodical, and we operate down these known paths that have been traveled by hundreds of years of medical experience. We're trained that failure is to be avoided at all costs. See, for us, failure can lead to harm or death. Not so in innovation. Failure can lead to growth and success. To quote Ken Robinson, if you're not prepared to be wrong, you'll never come up with anything original. Innovation is fast, risky, and disruptive. Failure is part of the learning process. The sooner you find out what doesn't work, the sooner you can move on to something that does. Well, how does this relate to us? Like a new idea, emergency medicine's problems are undifferentiated, a blank canvas. We have to keep an open mind and pivot when the patient's clinical status is not improving as expected. This is the innovative process. See, this is what people think it means to be an innovator. Many people wouldn't consider themselves the next Steve Jobs. That's generational genius. This type of innovation is like catching lightning in a bottle, extremely difficult and impossible to replicate. No, our job is to develop tools to help ensure that lightning strikes in the same spot more than once. And we have countless tools at our disposal. Observe your surroundings and find problems. And remember, there is a huge difference between finding a problem and understanding it. It's only when a problem is understood that we can begin finding solutions. And what a better way to explore possible solutions than research and quality improvement projects. Research and QI allow us to be creative, formulate ideas, ask questions, and most importantly, test them. We can pivot faster and in real time assess the impact of these changes, just like a startup company. Have an idea? Look internally and find resources within your organization for commercialization and implementation. Or look in your community for innovation hubs where the efforts of entrepreneurs are supported. You may be surprised at the resources that are within reach. Innovation is all around us. Find organizations in your area where you can get involved and learn. You don't need ideas either. Companies who produce products for healthcare need our opinions. We are who these products are designed for. Do not underestimate the importance of the end user. Most importantly, observe and explore. If you want to make innovation a part of your career in medicine and feel that the barrier of entry is too high, reach out and look for ways to get involved. There are people and organizations within your backyard who can help. See, we all got into healthcare to help people. Let us scale our ability to help through innovation. Thank you.
Hello, I'm Luke Seigan, Assistant Residency Director at New York Presbyterian Brooklyn Methodist Hospital. Thrilled to be part of the Ignite competition. For the next 5 minutes, I will be discussing history lessons on medical experimentations and maltreatment of minorities. And it's apropos because we are living in an epic time of Black American and world history due to the COVID-19 pandemic, of course. And when we look back at the COVID-19 virus and its coronavirus vaccine, we will see a disproportionate effect of the disease on Black Americans, as we know. And then we will try and analyze and examine the great hesitancy of Black Americans to take this vaccine and compare it to white, Hispanics, and Asians. And we already know that 73% of the Black Americans who won't take it claim it is because of the prior transgressions that drive the reasoning behind the hesitancy and distrust. So how did we get here? Well, it started 70 years ago, when there was a vaccine race to fight the polio virus. The race was between Dr. Jonas Salk and Dr. Albert Sabin. And Dr. Salk beat out Dr. Sabin and came out with the live attenuated poliovirus vaccine. However, in haste of production, Cutter Laboratories in California accidentally distributed live viruses, infecting 40,000 children, resulting in 51 paralyzed and 4 dead. Hell, that will give everyone concerned about vaccines. But to truly understand what Black Americans are concerned about, we need to leave our comfort zone and discuss some uncomfortable things. Just like going in the gym and getting uncomfortable lifting a weight or telling our residents to see uncomfortable pathologies, that's the only way we get better. So let's start with the renowned surgeon, former president of the AMA, founder of Women's Hospital in New York City, and the quote-unquote father of gynecology, Dr. J. Marion Sims. Dr. J. Marion Sims was world-renowned in the 19th century. He discovered groundbreaking surgery techniques to treat serious pelvic injuries. The way he perfected those techniques was not on his patients, but on his slaves, like Anarcha here sitting in his portrait. Painful operations, all done without consent, and mostly done without any anesthesia or analgesia. The procedure here, which is repair of the vesico-vaginal fistulas, was done without anesthesia. And the reason why is because it didn't justify the trouble and risk attending the administration, as quoted by Dr. J. Marion Sims. Now, looking at that through a 2021 lens, you understand that some may say the operating theater was quite barbaric, but then you learn that ether was around, and Dr. Sims was treating patients with ether. It was his white patients' wives who had vaginismus, and he would give them ether so that their husbands would have sex with them. And that there was adequate anesthesia, and he was saving it until after the procedure so that his slaves would be addicted to heroin. Then you start losing the benefit of the doubt when you start considering that. And I would be remiss if I didn't discuss the Tuskegee experiment very briefly when talking about medical experimentation. This started in 1932. It was first known as the Untreated Syphilis Male in Negro Study. It was supposed to provide free healthcare for 6 months, and instead men went through painful testing without getting, with only getting microdoses of arsenic and mercury. Introduction of penicillin did not change the course of this experiment. Penicillin was introduced in 1943. Treatment was still withheld until the 40 years when it was concluded. 28 died of syphilis, 100 died of related causes, and it was passed on to family members. And as tragic as these numbers and these facts were, the Tuskegee Legacy Project in 2006 showed surveys that this Tuskegee excuse did not correlate with what Black Americans distrust the healthcare system, but it was a small piece of the historical puzzle, and that puzzle includes Dr. Sims. But it also includes the HeLa cells, which the Tuskegee labs used to make Dr. Salk's polio vaccine. Those HeLa cells, which are immortal cells that have done so much in the last 70 years, they were actually used for the coronavirus vaccine. HeLa stands for Henrietta Lacks, who was a cancer patient. Her cervical cells were used and cultured without her permission, without her consent. It took 20 years for her family to find out about this. It took 60 years for NIH and Hopkins to try and make right with the family. Finally, now Johns Hopkins naming buildings after her on their campus. NIH is granting access and giving the right for the family to have control of her genome. And it must have been quite uncomfortable for these two mega institutions to fess up and try and right this wrong. But it's never too late to leave our comfort zone. It's never too late to bring up these difficult topics and conversations and try to right the wrongs that are happening today. That's how we can become better doctors for our patients and just better partners in the world. And then maybe, as Dr. Reuben Warren, who's the current director of Tuskegee University, says, maybe we could prove ourselves trustworthy and trust will follow. I appreciate for you taking the time and listening to this, and I hope you enjoy the rest of your day, and thank you very, very much for having me.